Welcome to the deep dive. Today, we're laser focused on a core area for vascular surgeons, acute venous thromboembolic disease, that's DVT, deep vein thrombosis, and PE, pulmonary embolism.
Right. The essentials.
Exactly. Think of this as your streamlined guide, pulling the essential threads from Section 22, Chapters 146 through 153 of Rutherford's Vascular Surgery and Endovascular Therapy.
It's a huge topic, definitely.
It is. It's comprehensive, so our aim is to extract the critical knowledge you need for immediate application in your practice. Okay, let's unpack this. Chapter 146 kicks us off with epidemiology and pathophysiology.
Yeah, and it's quite striking how much the risk of VTE varies depending on the patient group. Chapter 146 really drives this point home.
Like how?
Well, for example, in spinal cord injury patients undergoing systematic screening, DVT rates can be as high as 81%, huge numbers.
Wow.
But then, in contrast, ICU patients receiving prophylactic measures, C rates drop significantly, maybe 10% to 18%.
Well, so prophylaxis works.
It does, but here's a crucial point for our listeners. Chapter 146 also highlights that a significant portion, maybe up to 64%, in some studies of VTE events in critically ill individuals, are actually diagnosed after they've left the ICU.
After discharge. That's surprising.
It is. It really suggests that the period following intensive care discharge is a particularly vulnerable time where, vigilance is absolutely key.
That's a really important takeaway for our listeners. And building on that, Chapter 146 sort of shifts our perspective on why VTE occurs, doesn't it?
It does. We're moving away from just a simple provoked versus unprovoked classification,
Right,
and placing greater emphasis on pinpointing potentially reversible risk factors. Understanding these underlying contributors is, well, obviously essential for targeted management strategies.
Makes sense. And Table 146.1 in that chapter, that offers a very practical breakdown, right, with the point values.
Exactly. That's what's so useful here, the assigned point values. It introduces a more systematic approach to risk assessment. You'll see factors ranging from 1 point, like, say, age between 41 and 60 or minor surgery,
Okay.
up to 5 points for scenarios such as elective major lower extremity arthroplasty or acute spinal cord injury. The table also includes risk factors specific to women, like OCP use and pregnancy.
So this kind of scoring helps ensure we consider the full spectrum of potential contributors to a patient's VTE risk.
Precisely.
Right. And in the surgical context, the Caprini risk score, which figure 146.1 illustrates, that's a widely used tool for preoperative risk assessment. It provides a structured framework.
Yeah, very common.
But it's important to remember that for our medical patients, scores like Padua and Improve are often more appropriate. So the clinical setting really dictates which risk stratification tool is most valuable.
Absolutely, you tailor the tool. And if we connect this to specific patient groups, Chapter 146 also sheds light on some important nuances.
Like VTE in kids.
Yeah, exactly. While VTE in children is relatively uncommon, it's being recognized more frequently, especially in hospitalized kids. Then we have patients with a prior history of VTE.
Where the recurrence risk is high.
A substantial risk, yes.
Mm-hmm.
And inherited factors like factor V Leiden can play a role. Interestingly, though, the chapter notes that testing for factor V Leiden might not be all that helpful in predicting recurrence risk.
That's interesting. I thought it would be.
It's a common misconception. The chapter also provides a good overview of other inherited and acquired thrombophilias that can contribute.
And malignancy is a really significant risk factor. Chapter 146 clearly outlines that markedly increased risk in cancer patients.
Hugely increased.
It even suggests the possibility of an undiagnosed cancer in cases of seemingly unprovoked DVT.
Right, the so-called idiopathic DVT. You have to consider it. The chapter lists specific cancers with particularly high VTE rates: pancreatic, kidney, ovary, lung, stomach.
And the mechanisms are fascinating, aren't they? It's not just one thing.
Not at all. It's complex. Ranges from physical compression by the tumor itself
Right.
to the direct procoagulant effects of cancer cells releasing substances like tissue factor and cancer procoagulant. Even the treatments, chemo, radiation, they can elevate the risk too. It's a very multifaceted interaction.
Yeah, it really is.
And what's noteworthy here is the chapter's observation that cancer-associated DVT can sometimes be less responsive to standard anticoagulants,
Why is that?
possibly due to these prothrombotic factors released by the tumor itself. The chapter also highlights how preoperative activation of the coagulation system in cancer patients can significantly increase the risk of postoperative DVT.
Okay.
And it's crucial for surgeons to keep in mind that VTE risk isn't confined to the immediate perioperative period. It can extend well beyond hospital discharge.
Right, especially after certain procedures.
Exactly, particularly things like gynecologic and major abdominal surgeries. This prolonged risk window requires careful consideration for extended thromboprophylaxis in selected patients.
Trauma patients also fall into this elevated risk category, as Chapter 146 briefly explains.
Yeah, the body's response to major injury, it can create a hypercoagulable state. You get depletion of natural anticoagulants, changes in the fibrinolytic system.
And then there's pregnancy, a period of substantially increased VTE risk.
Oh, absolutely. 6 to 10 times higher than in non-pregnant individuals at the same age.
And it's not just the third trimester, right? That thinking has changed.
That's right. Contrary to older beliefs, current data suggests a more even distribution across trimesters, with a particularly high incidence in the postpartum period, especially following a cesarean section.
And that raises the point about hormones. Chapter 146 details the increased risk with estrogen-containing meds like OCPs and HRT.
Definitely. The risk with third-generation oral contraceptives is especially noteworthy, particularly in women who also have factor V Leiden. That combination is potent.
Right.
And even though the estrogen doses in postmenopausal HRT are generally lower, there's still an elevated risk, particularly during that first year of use.
The link between blood type and VTE risk is another surprising detail in Chapter 146, blood type A.
Yeah, it appears that individuals with blood type A have a slightly higher prevalence of VTE, while those with type O tend to have lower levels of von Willebrand factor, which is key in coagulation.
Interesting. And what about inflammatory conditions?
Well, inflammatory bowel disease, both Crohn's and ulcerative colitis, is associated with an increased risk of VTE, often in younger patients, active disease, sometimes unusual locations.
And lupus, SLE.
Similarly, systemic lupus erythematosus, especially if antiphospholipid antibodies like lupus anticoagulant or anticardiolipin antibodies are present, carries a significantly higher risk of both arterial and venous thrombosis.
Okay. What about varicose veins? That seems like it should be a risk factor.
It's a bit debated, actually. Chapter 146 points out that while it's often perceived as a risk factor, the evidence isn't entirely consistent, especially in younger women without other major risks.
But age plays a role?
Age seems to modify it. There's a stronger association between varicose veins and DVT in older individuals. And while varicose veins might increase DVT risk, the chapter notes the PE risk isn't as significantly elevated.
Okay. And briefly, obesity and cardiac disease.
Yeah, the chapter touches on those. Notes a more consistent association between obesity and VTE in postmenopausal women and in cases of recurrent DVT. And, it's worth noting, the sobering statistic from Chapter 146, autopsy studies have revealed a significant incidence of PE in hospitalized patients, with a notable percentage being fatal.
A grim reminder. And as a final point from Chapter 146, it directs us to the Connors reference regarding the utility of thrombophilia testing. What's the takeaway there?
Basically, it suggests that the clinical scenarios where testing is truly indicated are actually quite selective. You don't need to test everyone.
Got it. Okay, let's move on to Chapter 148. This gets into the nitty-gritty, presentation, diagnosis, and medical treatment of acute lower extremity DVT. For a vascular surgeon, how should they initially approach a patient suspected of having a DVT?
Well, Chapter 148 stresses the importance of a thorough clinical assessment first and foremost. And then if you suspect DVT, a logical diagnostic workup is essential.
Starting with D-dimer.
Often, yes. The chapter details the range of tests, starting with D-dimer. What's key to remember here is its role as a rule-out test, especially in low and intermediate risk outpatients.
And it mentions age-adjusted cutoffs.
It does, which can improve the test's specificity in older patients, potentially reducing the need for unnecessary imaging. Very practical point.
Okay, and then we move to imaging. Duplex ultrasound is the mainstay, right?
Absolutely. And Chapter 148 discusses both approaches, serial limited ultrasound versus whole leg ultrasound.
There's some debate there, particularly for distal DVT.
Exactly. It highlights the ongoing debate surrounding the management of distal DVT and the ACCP guidelines' somewhat neutral stance, although they do suggest considering whole leg imaging in specific situations.
But does one method perform better for proximal DVT?
Interestingly, the chapter points out that studies haven't consistently demonstrated a significant difference in diagnostic accuracy between limited and whole leg ultrasound approaches for proximal DVT.
What about older or less common tests? Venography.
Chapter 148 covers venography, which, was the historical gold standard, but it's used much less now because it's invasive.
And CT venography, CTV.
CTV is accurate for detecting proximal DVT, but it has limitations cost, radiation exposure, and the potential for false positives.
Okay. Then there's MRV, magnetic resonance venography.
Right. As the chapter explains, it works by detecting differences between moving blood and stationary tissue. Contrast-enhanced MRV is generally more accurate, especially where blood flow is slow. Figure 148.6 shows its use in things like pelvic congestion syndrome.
But it has downsides.
It does. Longer imaging times, MRI incompatibility issues, the gadolinium risk in renal disease, limited availability sometimes, and it really depends on experienced interpretation. The chapter highlights specific scenarios where it might be particularly useful.
And PTCT.
Briefly mentioned, 18F labeled fluorodeoxyglucose PTCT, but the clinical data supporting its use in DVT diagnosis is pretty limited right now.
Okay. Chapter 148 then revisits the acquired risk factors in Table 148.2, really emphasizing that high postoperative DVT risk after certain surgeries.
Yes, reinforcing the earlier points. And while testing for inherited thrombophilia is often considered,
We already touched on this.
right, the chapter points out again that most mild to moderate thrombophilias have a low predictive value for a first-time VTE.
So what is crucial for clinicians in terms of assessment tools?
The application of clinical prediction rules. Chapter 148 details the Wells criteria for DVT in Table 148.1. This is a well-validated tool for stratifying risk in outpatients.
But with limitations.
Definitely. The chapter appropriately cautions that it may not be as reliable in certain populations, particularly pregnant patients and those already hospitalized.
So how do you put it all together? The diagnostic strategy.
It emphasizes integrating risk stratification, using tools like the Wells score with D-dimer testing in low and intermediate risk folks, and then proceeding directly to imaging in high-risk cases.
And DVT diagnosis during pregnancy? You mentioned the Wells score is limited there.
It is. Pregnancy presents unique challenges. Wells score and D-dimer have limitations. The chapter mentions the left rule, a pregnancy-specific tool, but notes it hasn't been prospectively validated yet, so it's still a tricky area.
Okay. Now we get to the core of Chapter 148. Medical treatment of acute lower extremity DVT. What are the goals?
The chapter clearly outlines the primary goals. Stabilize the existing thrombus, prevent it from extending or embolizing to the lungs.
Right. Prevent PE.
Exactly. Promote the body's natural clot breakdown or fibrinolysis, and ultimately reduce both immediate morbidity and long-term mortality.
And the cornerstone of therapy is?
Anticoagulation. Unequivocally stated in the chapter, that's the mainstay.
What about non-drug measures? Elevation, compression.
Chapter 148 briefly addresses those. Early ambulation, compression therapy are generally good. Leg elevation, the evidence supporting routine use is a bit mixed.
Okay. From an anatomical perspective, how long do you treat proximal DVT?
The chapter emphasizes that a minimum of 3 months of therapeutic anticoagulation is the standard of care for proximal DVT.
But what about more aggressive interventions? Lytics, thrombectomy.
Good question. The chapter discusses their role, but only in very specific and severe clinical scenarios, namely phlegmasia ceruleus dolens, that limb-threatening extensive DVT,
Okay.
or extensive iliofemoral DVT within the first 14 days, and importantly, only in patients deemed to be at low risk of bleeding.
So not for everyone.
Definitely not. And it's important to remember, as the chapter highlights, that consistent benefit hasn't been definitively shown in the big randomized trials like CAVIT and PCDT for most patients with acute proximal DVT.
So what does guidelines say? ACCP.
Consequently, the ACCP guidelines, as summarized in Chapter 148, generally favor anticoagulation alone over catheter-directed thrombolysis, or CDT, for the majority of acute proximal DVT cases.
But there are exceptions.
Yes. Reserving CDT for instances of impending venous gangrene and a carefully selected subset of patients with iliofemoral DVT.
Got it. Now, the management of distal DVT below the knee, that's a known area of clinical debate, right?
It is, as Chapter 148 discusses, the risk of PE from isolated distal DVT is generally lower, and progression to the proximal veins happens in maybe only about 15% of cases.
Doesn't the CACTEF's trial look at this?
It did, but unfortunately it was underpowered and didn't provide definitive answers. As a result, current guidelines are somewhat conflicting.
How so?
Well, the ACCP suggests serial imaging for low-risk distal DVT and anticoagulation for high-risk cases. But other expert recommendations, like from Strafe and colleagues, tend to favor anticoagulation more broadly.
So how do you decide?
The chapter does provide a helpful list of risk factors that increase the likelihood of proximal extension in isolated distal DVT, which can aid in that clinical decision-making. Things like extensive clot, symptoms, positive D-dimer.
Okay, let's talk anticoagulation options. Chapter 148 breaks it down nicely.
Yes, logically divided into the initial phase, short-term treatment, typically the first 3 months, and then extended therapy if needed.
And the key message is start treatment fast if you suspect DVT.
Cannot be overstated. Prompt initiation is critical. Historically, the standard was heparin, usually unfractionated heparin or UFH, bridged to a VKA like warfarin.
And now we have more options.
Many more effective options. Low molecular weight heparins, LMWH, fondaparinux, and of course, the direct oral anticoagulants, the DOACs. Table 148.3 in the chapter gives a useful comparison.
And the chapter covers mechanisms, risks.
Briefly outlines mechanisms, efficacy, bleeding risks, other things like HIT, heparin-induced thrombocytopenia, and crucially, it highlights the availability of specific reversal agents for the DOACs.
And dexamethasone alpha and idarucizumab.
Exactly. And dexamethasone alpha for the factors ACE inhibitors, idarucizumab for dabigatran. The chapter also summarizes the pivotal DOAC trials, Einstein for rivaroxaban, Amplify for apixaban, Hokusai VTE for edoxaban, showing their non-inferiority or superiority compared to traditional therapy.
Okay. Chapter 148 also addresses cancer-associated VTE, or CAT. That's complex.
Very complex. As it explains, these patients face a heightened risk of both recurrent thrombosis and bleeding complications.
And management challenges.
Yeah, things like nausea, vomiting affecting oral med adherence, potential drug interactions with cancer therapies, the thrombocytopenia. It could be tough.
But the treatment landscape is changing there, too, with DOACs.
It is. The chapter highlights recent clinical data supporting the use of oral anti-Zexu inhibitors, edoxaban, rivaroxaban, apixaban, as effective alternatives to LMWH for the majority of CC cases.
So guidelines are catching up.
They are. Updates from NCCN and ASCO now include recommendations for oral anti-Zexin inhibitors. Although the ACCP still generally favors LMWH as the preferred initial treatment in their latest guidance mentioned here.
So still some variation.
A bit. But regardless of the agent chosen, careful assessment of bleeding risk and potential drug interactions is absolutely critical in this population. The chapter also reiterates the importance of adjunctive measures like leg elevation and early ambulation with compression.
Right. And finally, from 148, the duration of treatment. How is that decided?
It's largely determined by the individual patient's risk of recurrent VTE versus their risk of bleeding. Plus, whether the initial VTE was provoked by something transient or was unprovoked or idiopathic.
And active cancer keeps the recurrence risk high.
Persistently higher risk, yes. The chapter also clarifies an important point. The initial duration, usually 3 months, doesn't affect the subsequent recurrence risk after stopping treatment.
Okay, so what are the recommendations for extended therapy?
The chapter summarizes ACCP and ISTA recommendations. It discusses risk stratification factors for unprovoked VTE. We mentioned hereditary thrombophilias earlier. FVL and prothrombin gene mutations are relatively weak predictors of recurrence.
But protein C, S, antithrombin deficiencies.
Those are associated with a higher risk. Other factors like male gender, persistently elevated D-dimer after stopping anticoagulation, residual thrombus on ultrasound, and a proximal DVT site also increase recurrence risk.
Are there scores to help estimate this risk?
Yes, the chapter mentions several clinical prediction scores, Vienna, DANGE, HERDO2, which can help estimate recurrence risk.
So what's the general recommendation? 3 months or longer?
Generally, 3 months for a provoked proximal or isolated distal DVT, or for an unprovoked VTE in patients at high bleeding risk. Extended anticoagulation is recommended for patients with persistent provoking factors or for those with unprovoked VTE who don't have a high bleeding risk.
And you have to keep reassessing.
Absolutely. The chapter emphasizes the need for at least an annual reassessment of the risks and benefits of continuing anticoagulation. It's not a one-time decision.
Okay, great summary of medical management. Moving into Chapter 149, we now shift focus to surgical and interventional treatment. The rationale here is mainly about reducing post-thrombotic syndrome, PTS.
Exactly. The central idea is that actively removing the thrombus, especially in extensive proximal DVT, may reduce the incidence and severity of that debilitating PTS.
And what predicts PTS? Chapter 149 highlights iliofemoral DVT, IFDVT.
That's right. IFDVT, involving the iliac and conifemoral veins, stands out as a major risk factor for developing severe PTS. The chapter highlights the strong correlation between IF-DVT and chronically elevated venous pressures in the leg.
Which leads to long-term problems.
Increased long-term morbidity pain, swelling, skin changes, ulcers. It also mentions that patients with a larger initial thrombus burden are at higher risk for recurrence. This understanding really underscores the rationale for considering aggressive thrombus removal in carefully selected patients.
Okay, so what are the options? Chapter 149 discusses pharmacomechanical thrombolysis, PMT.
Right. The primary goal of PMT is to rapidly reduce the clot burden. However, as the chapter points out, these procedures can be time-consuming, carry potential risks like bleeding, and they can be costly.
But they can work. It mentions the Salesian study.
Yes, that study showed high rates of venous patency and preserved valve function in patients with acute DVT treated with catheter-directed thrombolysis, CDT, within 14 days of symptoms starting.
Then we have the big trial, the ATTRACT trial. Chapter 149 details that.
It does. ATTRACT is the largest randomized trial comparing pharmacomechanical CDT plus anticoagulation versus anticoagulation alone for proximal DVT.
And what did it find? Did CDT reduce PTS?
Well, Chapter 149 outlines the study design, stratification, outcomes. Interestingly, despite the theoretical benefits, ATTRACT did not show a statistically significant reduction in the overall incidence of PTS at 2 years in the PCDT group compared to anticoagulation alone.
So that dampened enthusiasm a bit.
It did temper the initial enthusiasm for using PCDT widely in all patients with proximal DVT, though some subgroup analyses suggested potential benefit in more severe IF-DVT.
Okay. What about open surgery? Operative venous thrombectomy for IF-DVT.
Chapter 149 delves into that technique. It presents data suggesting that in appropriately selected patients, surgical thrombectomy might achieve better short- and long-term patency rates compared to anticoagulation alone,
And preserve valve function.
and potentially offer a greater chance of preserving the function of those crucial femoropopliteal venous valves, which helps prevent reflux and PTS.
And Box 149.1 outlines the technique.
Yes, that's a really valuable resource for surgeons. It clearly outlines the fundamental principles. Complete thrombus removal, ensuring unobstructed inflow and outflow, correcting any underlying lesions like stenosis or compression.
Right, like May Forner.
Exactly. And implementing measures to prevent early rethrombosis, maybe a temporary AZ fistula, continuous anticoagulation, or post-op catheter-directed lytics if needed, especially after infrainguinal thrombectomy. The chapter details the steps using Fogarty catheters, often with ultrasound guidance.
And intraop imaging is key.
Critical. The chapter emphasizes intraoperative phlebography or fluoroscopy to check for iliac vein stenosis or compression. If you leave that untreated, the risk of rethrombosis and PTS goes way up.
Makes sense. Post-op care.
As outlined in Chapter 149, continued anticoagulation, leg elevation, compression, early ambulation. If a temporary IVC filter was placed, timely removal is important, and routine follow-up with duplex and venous function studies.
So how do you choose the right option?
Chapter 149 gives practical guidance. It suggests thrombus removal strategies should be strongly considered in symptomatic patients with acute IF-DVT, particularly those who are young, active, and have a low bleeding risk.
And if the common femoral is occluded?
It highlights that those patients should likely be hospitalized and promptly evaluated for potential thrombus removal. The chapter also briefly describes segmental PMT using devices like trellis and ECOs, shown in Figure 149.8, for more targeted clot removal.
And there's an algorithm.
Yes. Chapter 149 culminates in a helpful algorithm for managing acute IF-DVT. Starts with immediate anticoagulation, supportive measures, then rapid CT of chest, abdomen, pelvis to assess the vena cava and rule out PE.
Then the decision point for thrombus removal.
Exactly. Considering PMT CDT or surgical thrombectomy for physically active patients without contraindications, especially if underlying lesions can be fixed. It also mentions considering a temporary IVC filter for free-floating thrombus. The chapter wraps up by referencing studies supporting CDT benefits in IF-DVT for reducing PTS.
Okay, clear. Now, a quick shift with Chapter 150, preventing catheter-related thrombosis. What's the main point there?
It's pretty focused. The primary message is the crucial role of both the catheter insertion site and, more importantly, the position of the distal tip.
Where should it be?
Based on a big review, the French National Federation of Cancer Centers guidelines strongly recommend the distal tip of all central venous catheters should ideally be located right at the junction of the right atrium and the superior vena cava.
Why there?
Optimal positioning there minimizes the risk of catheter-related thrombosis. It's a very practical, evidence-based recommendation for anyone placing central lines.
Good takeaway. Now, chapter 152, a big one, pulmonary embolism. It starts by emphasizing the varied presentation.
Absolutely. PE can manifest across a huge spectrum from asymptomatic, found incidentally, to tragically fatal events. Because of this variability, the chapter stresses maintaining a high index of suspicion.
Common symptoms: dyspnea, chest pain.
Those are common, yes. Dyspnea, chest pain, syncope, sometimes hemoptysis. But the symptoms vary depending on the clot burden, location, and the patient's underlying cardiopulmonary reserve.
Okay, diagnosis. What about lab tests?
Biomarkers.
Chapter 152 covers diagnostics. Lab biomarkers of right ventricular dysfunction, troponin, BNP or NT-proBNP, HFABP are discussed.
Are they diagnostic?
Not specific enough to diagnose PE on their own, but they're very useful in risk stratifying patients already diagnosed with PE, helping identify those at higher risk for bad outcomes. Age-adjusted cutoffs are mentioned too.
ABGs.
ECG.
Arterial blood gases are generally nonspecific, though hypoxemia might have prognostic value. Pulse oximetry is a good non-invasive first step. ECG, also not sensitive or specific. The classic S1Q3T3 pattern is seen in less than 20%. Its main utility is often ruling out an MI.
Chest X-ray.
Usually nonspecific, mainly helps rule out other things like pneumonia.
So the workhorse is CTPA.
Computed tomographic pulmonary angiography, yes. That's the mainstay for diagnosing PE. As the chapter states and figure 152.1 shows, it directly visualizes the thrombus in the pulmonary arteries.
What about echo?
Echocardiography isn't routine for diagnosis in stable patients, but it's critical in unstable patients with suspected high-risk PE. RV dysfunction on echo can justify emergency reperfusion if CTPA isn't feasible. TE can sometimes spot thrombus in transit.
Any other imaging? VQ scans.
VQ scans are used less often now, maybe in pregnancy or severe renal insufficiency. MR pulmonary angiography is an alternative if CTPA is contraindicated, but it's technically complex, maybe lower resolution. Invasive pulmonary angiography is historical, mostly used now if catheter intervention is planned.
Okay. Risk stratification is crucial in PE management.
Absolutely, as Chapter 152 discusses, clinical probability scores like Wells or Revised Geneva help estimate pretest probability.
And stratifying for adverse outcomes.
Yes, that's key for guiding treatment. High-risk PE with hemodynamic instability has high early mortality. The PSC score, simplified PC, BOVA, FAST scores. Table 152.2 summarizes these help estimate 30-day mortality risk.
But you need more than just the score.
You really need to combine these clinical scores with imaging findings like RV dysfunction on CT or echo and lab biomarkers like troponin or BNP. That gives a more comprehensive risk assessment. Table 152.3 details this further for intermediate risk patients, leading to the ESC intermediate low and intermediate high risk categories.
Okay, treatment of PE in Chapter 152 starts with supportive care.
Yes, initial steps are oxygen, hemodynamic support if needed fluids, pressors.
And anticoagulation.
Immediate initiation is critical, just like with DVT, if PE is suspected or confirmed. Options are the same. UFH, LMWH, Phonoparanux, DOACs.
Easy filters.
Discussed in more detail in the next chapter, but Chapter 152 mentions the key indications. Contraindication to anticoagulation or recurrent PE despite anticoagulation.
Thrombolysis, when is that used?
Thrombolysis, using clot-busting drugs, is critical for high-risk PE, hemodynamically unstable, and in selected intermediate-risk patients, those with RV dysfunction and elevated biomarkers, but without hypotension.
Is there a time window?
Greatest benefit is usually within 48 hours of symptoms, but it might still be useful up to 14 days. Contraindications are similar to those for MI.
Systemic thrombolysis is standard for high-risk PE.
Universally recommended for high risk. Its role in intermediate-risk PE is more controversial. The standard regimen is 100 milligram altolas over 2 hours.
Does it improve mortality?
A meta-analysis showed lower mortality with thrombolysis versus anticoagulation alone, but also a higher risk of major bleeding and intracranial hemorrhage, especially in older folks. Interestingly, the chapter notes it's still underutilized in unstable patients despite the benefit.
What about catheter-directed interventions, CDI?
Also discussed in Chapter 152. Inserting catheters into the pulmonary arteries to deliver lytics locally or mechanically remove clot. Initially thought to be safer than systemic lytics regarding bleeding.
That may be not quite as safe as hoped.
Exactly. The chapter cautions they aren't without risk, but might be preferred in patients with a high bleeding risk. It outlines technical aspects and shows various devices in figures 152.3 through 6.
Surgical embolectomy, ECMO.
Surgical embolectomy is reserved for massive PE with contraindications to lytics or failed CDI. ECMO can provide temporary hemodynamic and respiratory support in severe cases.
Can low-risk patients go home?
Early discharge and home treatment might be feasible for carefully selected low-risk PE patients meeting specific criteria, like PC score, with good outpatient support. The chapter points to treatment algorithms, like from PERT consortia for guidance.
And Chapter 152 covers special populations, too. Incidental subsegmental PE.
Yeah, those small peripheral clots found incidentally. Their clinical relevance is uncertain, treatment is controversial, depends on risk factors, symptoms, bleeding risk. Sometimes observation is reasonable.
Thrombus in transit.
Rare, potentially fatal. Management varies: anticoagulation, colphytics, thrombectomy. Surgery might be preferred if there's a PFO.
Pregnancy and PE.
A leading cause of maternal mortality. Postpartum risk is high. Diagnosis is tricky, symptoms overlap, prediction rules aren't validated. D-dimer is elevated physiologically. Lower extremity duplex first is often helpful. If negative, CTPA is usually preferred. VQ scan is an alternative.
Cancer and PE.
Higher VTE prevalence, higher risk of adverse PE outcomes. LMWH has been first line, but NOAC, ACE-DOACs are emerging alternatives, except maybe in GI cancers. Long-term anticoagulation is often needed.
Non-thrombotic PEs.
Briefly mentioned, amniotic fluid embolism, air embolism, foreign material embolization where retrieval might be needed.
And prognosis after PE.
Varies considerably. Depends on obstruction severity and RV function. RV failure is a common cause of death. RD strain predicts adverse outcomes. Anticoagulation thrombolysis improves survival, but later mortality is often from other CV risks or cancer. And patients are at risk for recurrence or CTEP. The chapter points to key references and algorithms.
Okay, great overview. Our final chapter in this deep dive is 153, all about IVC filters. It starts with designs.
Right. Chapter 153 categorizes them. Permanent filters and optional or retrievable filters. Highlights the features of each.
And complications are key to understand.
Absolutely crucial. Chapter 153 details them. Migration or embolization moving more than 2 centimeters. Thrombotic occlusion of the filter itself. Filter tilt over 15 degrees. And filter leg penetration through the vena cava wall.
So when should filters be used? What about trauma patients?
The evidence is reviewed. In trauma, a meta-analysis showed lower PE incidence with prophylactic filters. A trial suggested benefit if long-term anticoagulation isn't possible. Current recommendation: reserve filters for trauma patients with documented VTE when anticoagulation is contraindicated, or maybe prophylaxis in select very high-risk patients.
What if a contraindication to anticoagulation develops later, after the acute VTE phase?
The chapter suggests against routine filter placement.
Recurrent VTE despite anticoagulation.
Also generally not recommended routinely. Better to figure out why anticoagulation failed.
Routine use in acute VTE treated with anticoagulation.
Strongly recommended again.
But maybe with advanced therapies like Orlix or thrombectomy.
Filters might be considered in select patients undergoing those therapies, especially if recurrent embolism risk is high during or after.
What about routine prophylaxis in trauma or major surgery without known VTE?
Generally recommended against in trauma. In bariatric surgery, insufficient evidence.
Orthopedic patients.
Filters may be effective in selected high-risk ortho patients with contraindications or complications of anticoagulation and documented VTE. Optional filters might offer temporary protection post-op.
Cancer patients.
Reserved for documented VTE, plus contraindications, complications of anticoagulation, and generally only if longer survival is expected. Discouraged in advanced disease with poor prognosis, high-risk general surgery. Not well-defined.
Okay. What about anatomical issues? IVC anomalies?
Chapter 153 addresses that. IVC transposition or duplication impacts placement. Might need suprarenal placement or 2 filters if duplicated.
How are they typically placed?
Venography. That's the standard approach, using fluoroscopy. Access via femoral, jugular, or antecubital veins. The chapter stresses needing venography before deployment to confirm landmarks, rule out thrombus, ensure proper positioning tip below lowest renal vein, base above iliac confluence. Figure 153.4 shows this.
Are there alternatives to venography guidance?
Yes. Transabdominal duplex ultrasound guidance is useful if contrast is contraindicated or access is tough. An intravascular ultrasound, IVUS, provides real-time imaging, can be single or dual access, helpful in obesity, or if venography is limited. Figure 153.9 shows IVUS.
Filter retrieval, how does that work?
Crucial for optional filters. Chapter 153 outlines the process. Confirm integrity radiographically, do venography to check for thrombus if clot is present. Retrieval might be deferred. Then use catheter snare techniques, femoral or jugular approach depending on filter type. Figure 153.10 illustrates snares.
What if it's stuck? Difficult retrieval.
The chapter addresses that. can happen if struts embed firmly. Describes advanced techniques, balloon displacement, loop wires, even bronchoscopic forceps or laser sheaths for really tough cases. Figure 153.11 shows some advanced methods.
Are there newer filter types? Convertible, temporary?
Yes. Chapter 153 discusses those, offering options for transient VTE risk. Techniques are extensions of traditional ones. Mentions the Venitec convertible filter and the Sentry filter with its bioabsorbable filament designed to degrade over time.
What about filters in the superior vena cava, the SVC?
An option in selected cases of upper extremity DVT when anticoagulation isn't possible. Conical filters with hooks are preferred. Discusses complications like malpositioning, perforation, thrombosis, but concludes SVC filters can be safe and effective in carefully selected patients. Figure 153.12 shows an SVC filter. The chapter ends with key references on complications, retrieval, and guidelines.
So there you have a rapid access guide to the management of acute VTE, focusing on DVT and PE, distilled from the essential knowledge within Section 22 of Rutherford's.
Yeah, covering a lot of ground.
We did.
Yeah.
And it's clearly a dynamic field with ongoing research and evolving guidelines, so continuous learning is essential for all vascular surgeons.
Absolutely. And if we connect this back to the practical realities for our listeners, this deep dive into Rutherford's really underscores the complexity of managing acute VTE. How do we best synthesize all of this information, from risk stratification to the nuances of different treatments, medical, interventional, the filters? How do we put it all together to provide optimal, individualized care for each patient?
Right.
That's the ongoing question, I think. That's what drives our practice and the evolution of this field.